Welcome to Pediatric Case Review. Today's lecture is a comprehensive case-based review of congenital neck masses in children, designed for general pediatricians and board candidates. Neck masses are a common and often anxiety-provoking finding in pediatric practice, and the differential diagnosis is broad. We will walk through 10 carefully crafted clinical cases covering the most common midline and lateral congenital neck masses, including thyroglossal duct cysts, dermoid cysts, branchial cleft anomalies, fibromatosis coli, lymphatic and venous malformations, and lingual thyroid. We will cover clinical recognition, embryology, diagnostic workup, surgical management, complications, and key differentiating features. Let us begin. Question 1. Clinical recognition. A 5-year-old boy presents with a painless 2 cm midline neck mass just below the hyoid bone. The mother noticed it 2 weeks ago after he had a mild cold. On physical examination, the mass is smooth, non-tender, and moves superiorly when the patient protrudes his tongue. What is the most likely diagnosis? Option A. Dermoid cyst. Option B. Thyroglossal duct cyst. Option C. Second branchial cleft cyst. Option D. Lymphadenitis. The correct answer is option B, thyroglossal duct cyst. Thyroglossal duct cysts are the most common congenital neck mass in children, accounting for approximately 70% of congenital neck lesions. Embryologically, they arise from a persistent remnant of the thyroglossal duct, the tract along which the thyroid gland descends from the foramen cecum at the base of the tongue to its final pretracheal position. The classic clinical signature is a midline location near the hyoid bone and characteristic upward movement with tongue protrusion or swallowing because the cyst remains attached to the hyoid and base of tongue. They often become clinically apparent after an upper respiratory infection when the cyst enlarges due to inflammation, as in this case. Question 2. Differential diagnosis of midline neck masses. A 3-year-old girl is brought in for a slow-growing, firm, non-tender mass in the submental region. Critically, the mass does not move with swallowing or tongue protrusion. On physical examination, the mass is superficial, mobile, and feels doughy on palpation. What is the most likely diagnosis? Option A. Dermoid cyst. Option B. Thyroglossal duct cyst. Option C. Ranula. Option D. Ectopic thyroid. The correct answer is option A, dermoid cyst. 2 findings in this case point away from a thyroglossal duct cyst and toward a dermoid. The mass does not move with tongue protrusion, and it has a characteristic doughy consistency on palpation. Dermoid cysts are congenital inclusion cysts that contain both ectodermal and mesodermal elements, such as hair, sebaceous material, and skin appendages, which accounts for their doughy feel. In the neck, they are typically located in the midline submental or submandibular region, superficial to the strap muscles. Unlike thyroglossal duct cysts, they have no connection to the hyoid bone or tongue base, so they remain stationary during swallowing. Treatment is simple surgical excision. Question 3. Lateral neck masses. An 8-year-old girl presents with a soft, non-tender mass along the anterior border of the upper third of the sternocleidomastoid muscle. Importantly, she has had intermittent drainage from a small pit in the same area since infancy, indicating a sinus or fistulous connection. What is the most likely diagnosis? Option A. First branchial cleft cyst. Option B. Cystic hygroma. Option C. Cat scratch disease. Option D. Second branchial cleft cyst. The correct answer is option D, second branchial cleft cyst. Branchial cleft anomalies arise from incomplete obliteration of the embryonic branchial apparatus, and second cleft anomalies account for approximately 95% of all branchial anomalies. Their characteristic location is along the anterior border of the sternocleidomastoid muscle, typically at the junction of the upper and middle thirds. They may present as a cyst, a sinus opening on the skin, or a complete fistula with intermittent mucoid drainage, as seen in this patient since infancy. First cleft anomalies, in contrast, are preauricular and near the external auditory canal, while third cleft lesions sit lower along the sternocleidomastoid. Definitive treatment is complete surgical excision of the cyst and any associated tract. Question 4. Diagnostic workup. You are evaluating a suspected thyroglossal duct cyst in a 4-year-old. Before surgical referral, which imaging study is most essential to perform? Option A. Computed tomography scan of the neck with contrast. Option B. Magnetic resonance imaging of the neck. Option C. Ultrasound of the neck. Option D. Thyroid uptake scan. The correct answer is option C. Ultrasound of the neck. Ultrasound is the initial imaging modality of choice for virtually all pediatric neck masses because it is radiation-free, well-tolerated, inexpensive, and highly accurate for characterizing cystic versus solid lesions. For a suspected thyroglossal duct cyst, ultrasound serves a critical surgical purpose, confirming the presence of a normal thyroid gland in its proper pretracheal location before any excision is attempted. This is essential because in a small but important subset of patients, the apparent cyst may actually represent the only functioning thyroid tissue the child has in the form of ectopic or lingual thyroid. Removing it without confirmation would render the child permanently hypothyroid. Ultrasound also assesses cyst characteristics and tract extension. Question 5. Neonatal presentation. A 3-week-old infant is brought in for a lump on the side of the neck. The mother notes the baby's head is always tilted to the right. On physical examination, a firm 2 cm mass is palpated within the body of the right sternocleidomastoid muscle. What is the most likely diagnosis? Option A. Fibromatosis coli. Option B. Third branchial cleft cyst. Option C. Neuroblastoma. Option D. Hemangioma. The correct answer is option A, fibromatosis coli, also known as sternocleidomastoid tumor of infancy. This is a benign fibroblastic proliferation within the sternocleidomastoid muscle, typically presenting between 2 and 4 weeks of age, exactly as in this case. 2 clinical clues are diagnostic. The mass is located within the body of the muscle itself rather than adjacent to it, and it is strongly associated with congenital muscular torticollis, causing the characteristic head tilt toward the affected side. The pathogenesis is thought to involve birth trauma or intrauterine positioning leading to muscle injury and fibrosis. Ultrasound shows characteristic fusiform enlargement of the muscle. Management is conservative, with gentle stretching exercises and physical therapy, and the vast majority resolve completely by 1 year of age. Surgery is reserved for refractory cases. Question 6. Vascular and lymphatic anomalies. A newborn is found to have a large, soft, fluctuant mass in the posterior triangle of the neck that transilluminates brightly when a light is applied. On physical examination, the mass is non-tender and easily compressible. What is the most likely diagnosis? Option A. Hemangioma. Option B. Teratoma. Option C. Lymphatic malformation, also known as cystic hygroma. Option D. Branchial cleft cyst. The correct answer is option C, lymphatic malformation or cystic hygroma. The defining clinical features are transillumination, soft compressibility, and location in the posterior triangle of the neck, which is the classic site. Transillumination occurs because these lesions consist of fluid-filled lymphatic channels and cystic spaces with thin walls. Approximately 50% are present at birth and 90% are evident by 2 years of age. They are commonly associated with chromosomal abnormalities, particularly Turner syndrome, Down syndrome, and Noonan syndrome, especially when detected prenatally. Hemangiomas, in contrast, are typically not present at birth, appear in the first weeks of life, and have a red or bluish color without transillumination. Management options include observation, sclerotherapy with agents such as OK432 or doxycycline, or surgical excision for selected cases. Question 7. Surgical management. A 6-year-old child is scheduled for excision of a thyroglossal duct cyst. The surgeon explains the cyst trunk procedure. What does this procedure involve? Option A. Simple excision of the cyst only. Option B. Excision of the cyst and the entire thyroid gland. Option C. Excision of the cyst, the tract, and the central portion of the hyoid bone. Option D. Incision and drainage of the cyst. The correct answer is option C. The cyst trunk procedure, described by Walter Sistrunk in 1920, remains the gold standard surgical treatment for thyroglossal duct cysts. It involves en bloc removal of 3 components: the cyst itself, the entire thyroglossal tract extending up to the foramen cecum at the base of the tongue, and crucially, the central portion of the hyoid bone through which the tract passes. The reason for removing the central hyoid is that the embryologic tract loops around the hyoid bone, and any remnant tissue left behind is the primary source of recurrence. The clinical impact is dramatic. Simple cyst excision alone carries a recurrence rate of approximately 50%, whereas the cyst trunk procedure reduces recurrence to less than 5%. This procedure is typically performed after age 2 and after any active infection has resolved. Question 8.